Yeah, if you have other things to do, you could do that.
Okay. See you later.
See you.
See you.
Hi. Harold,
Hello.
how are you doing today? Good afternoon.
I'm fine, thank you. I hope you're also fine.
Yes, I am. Yeah, and great. It's Hans that we are still expecting Hans.
Yes, I think he's going to be a bit late. He will just join for his presentation, and because he's currently traveling, I think.
Yeah, said so. Okay, maybe we'll start then. So
yeah,
hopefully before his talk, then we'll have him. So good morning, good afternoon, good evening, whatever part of the world you are. Thanks for joining us on this webinar that is jointly organized by the Society of Gynecology and Obstetrics of Nigeria and the European Endometriosis League, and on the special webinar talking about adenomyosis. This is probably, I cannot recall any other place where there's been a webinar on adenomyosis, either in Nigeria or in West Africa, that I can recall. And that's one of the reasons why we're doing this, because we've seen that it's probably one of the most misdiagnosed conditions in the female pelvis. And we think it's something that is worthy to be spoken about. Majority of the people also, or let me say some of the people that we diagnose with uterine fibroids, and we know how common fibroids are in this environment, also either have adenomyosis or they actually have adenomyosis and it's been misdiagnosed. So today we have a very rich panel to discuss this, both local and international. And we expect the president of the Society of Gynecology and Obstetrics to also join. And then also we have Dr. Kingsley Agolo, who will be introducing later on. And then we have Anne Steinenberg, and then we have Harald Krentel and Professor Ali from Shanghai. So while Krentel and Hans are from Germany, of course, Dr. Agolo is from Nigeria, like myself. So we hope to have a cross-fertilization of ideas and see how we can improve the knowledge and the diagnosis of this condition in this environment. So I think without much ado, we will not, since the president of Sogon is still being expected, I think we better just set things rolling. So I'm going to introduce Dr. Agolo, and then so that I can take the floor and start with, because one of the things is that we need to make a diagnosis first before we can even talk about treating adenomyosis. And that's where it comes in. We know the ultrasound is something that is quite portable and almost freely available everywhere. And therefore, we think it's something that will help us in the diagnosis of adenomyosis. So Dr. Kingsley Agolo is a consultant obstetrician and gynecologist. He's a sonologist and endoscopic surgeon. He's a fellow of the West African College of Surgeons and fellow of the National Postgraduate Medical College of Nigeria. He has authored many articles in both local and international journals. But what fascinates me about him is his interest in ultrasound. And since, like I said, ultrasound is really very freely available, I think is a low-hanging fruit for a low-resource economy like ours to be able to make more diagnosis of adenomyosis. So, Dr. Kingsley Agolo, it's so great to have you. Please, you can share your screen now, and you have the microphone. Thank you.
Thank you so much for inviting me. It's an excitement for me to be here, to be part of this process. So I thank you, your organizers, for inviting me to come and discuss the ultrasound diagnosis of this enigmatic disease, adenomyosis, with a focus on the Nigerian experience. I have no disclosures to make, so my pocket is empty. All right. Adenomyosis, yes, adenomyosis has always been considered the classic condition of multiparous women aged over 40 years, aged 40 years and over. These women usually have chronic pelvic pain and abnormal uterine and or abnormal uterine bleeding, with the condition believed to be diagnosed possibly only from histological examination of hysterectomy specimen of those women that are treated surgically. Sadly, evidence in Nigeria indicates that we have not moved from this long-held belief, despite the fact that the epidemiological scenario has changed completely with advances in imaging techniques, first with MRI in this paper by Togashi in 1988, and later with ultrasound in this work by Ligui Fedele in 1992. These advances in imaging techniques have shown that adenomyosis have shown improvement in adenomyosis diagnosis with identification of sonographic features of adenomyosis in young women of reproductive age. As far back as 1986, Binige and my teacher, Professor Eugene Okpere, showed that we in Nigeria were actually at par with the rest of the world in recognizing that there were challenges, with difficulties in the diagnosis of adenomyosis, and to work towards the prevention or elimination of its frequent misdiagnosis as uterine fibroids at surgery. But by 1991, while the rest of the world was moving forward with ultrasound and MRI, our diagnosis in Nigeria was still mostly post-operative, and we still believed that adenomyosis was commonest in multiparous women in the 5th decade of life. By 2019, we had gone full cycle back to 1986, with adenomyosis believed to be commoner in the 4th decade of life, and retrospective histology after hysterectomy still the diagnostic tool for the disease in Nigeria. And just last year here in 2020, right in the heart of the middle of COVID, Age4 and others working in Nnewi examined adenomyosis and uterine fibroids and reached the conclusion that histological examination is the only tool to differentiate adenomyosis from uterine fibroids. Again, the highest number of cases that they saw were women in their 5th decade of life. Is the global narrative different? Yes, I mentioned that earlier and provided the evidence as well. That transvaginal ultrasound and magnetic resonance imaging have improved the diagnosis and led to the identification of adenomyosis in young nulliparous women of fertile age, not just multiparous women in their 5th decade of life. Let's talk about ultrasound. That's why we are here. And so we find that with ultrasound, the disease is actually indeed common in younger women, with identification of endometrial-lined myometrial cysts and their association to adolescents and young women in this work by the 7 Gods group. Pinzati and Katrina Executives group showed us how young these women can truly be, with a demonstration or documentation of sonography features of diffuse adenomyosis in young 18-year-old and or 30-year-old women who have never been pregnant. Their effort showed us that adenomyosis actually develops earlier in reproductive life than we previously thought. In fact, Zanoni et al. Showed us again that the disease can be found in adolescents and that the prevalence of adenomyosis in young women, their own population of young women, presenting with pelvic pain amounted to about 46%. All of this with ultrasound. So we need to up the stakes in pre-surgical diagnosis of adenomyosis in Nigeria. We really need to ask questions whether histology is still the gold standard for the diagnosis of adenomyosis, because the evidence in Nigeria that histology is the gold standard for the diagnosis of adenomyosis and that the disease is common or most common in older women, older multiparous women, means that the condition will be largely underdiagnosed. I mean, you're not going to take a young, nulliparous woman, 28-year-old woman with chronic pelvic pain and or abnormal uterine bleeding and perform hysterectomy just because you want to rule out if she has adenomyosis. So there will be diagnostic delays, and with it are the attendant problems of application of the wrong treatment or misapplication of treatment by clinicians. So clearly, there's a need for pre-surgical diagnosis using non-invasive diagnostic methods like MRI or transvaginal scan. Indeed, when the results of transvaginal scan and MRI were compared with histological findings, the outcome showed that these imaging techniques correlated very well with histological diagnosis of hysterectomy specimen. In simple terms, transvaginal scan, MRI, and histology all compare together in the diagnosis of adenomyosis. None is superior to the other. This evidence led the authors of this meta-analysis and systematic review to recommend transvaginal scan as the first-line diagnostic imaging technique. Of course, transvaginal scan is widely available, of course, therefore more accessible, better tolerated by patients, and cheaper than MRI. Leaving MRI as the second-line treatment only if transvaginal scan is inconclusive. And transvaginal scan will be inconclusive. I mean, we can remove the inconclusive, it will be very few or none at all if transvaginal scan is performed by dedicated sonographers who can identify distinct ultrasound pattern of required in the diagnosis of adenomyosis. And so truly, Professor Hyacinth Honor and his team of fertility specialists demonstrated the sonography features of adenomyosis in their population of young infertile women in Nigeria. This is the only evidence documenting ultrasound finding of adenomyosis in the Nigerian population. However, but they did not actually state the exact sonography features of adenomyosis that they identified. Nonetheless, they identified these features in only 2% of their population. Recall from the evidence I provided here today that the estimated prevalence from histological diagnosis in Nigeria is about 10%. So why do we have this variance? This variance may be explained by inconclusive ultrasound reports like the one presented to us by this 28-year-old lady. She came to us seeking resolution of infertility, having been trying to get pregnant for the past 2 years. She also complained of severe dysmenorrhea and deep dyspareunia. She came with 2 ultrasound scan reports. The first one, this one here, was done on the 10th of August, and the sonographer used first the transabdominal probe, and then he described the liver, the gallbladder, the kidney, the pancreas, spleen, bowels, and then used the transvaginal probe to image the uterus and describe the uterus as normal in size, anteverted, and non-gravid. Now, what is normal in size? The exact measurement ought to have inputted in this report, so we are sure that the operator's subjective judgment is not in doubt. Because of course, Sakel and our friend Abu Mohammed showed us that globular uterine enlargement that is generally up to 12 cm in uterine length, that is not explained by the presence of fibroid, is a characteristic finding of adenomyosis. So we lose that information because the measurement is not there. And he described again the myometrium as he identified a tiny fibroid mass noted at the uterine wall and measures that. So conclusion was that features are in keeping with tiny uterine fibroids, but infertility persisted, dysmenorrhea persisted, and deep dyspareunia persisted. So as is common in Nigeria, patients drive their own treatment. And so she presented elsewhere for another ultrasound scan. So she had a second ultrasound scan on the 27th of August, about 17 days apart. And in the report, we noticed that the uterine length now measures approximately 11 centimeters and that the uterus is suddenly bulky. Importantly, the sonographer notes that there are ill-defined echogenic areas involving the posterior and frontal myometrial regions. These are terms used for the description of adenomyosis. The sonographer acknowledges the association of these terms with adenomyosis in his final report, where he notes query background adenomyosis, and the patient is advised to seek confirmation of his findings using a transvaginal scan. So she presented to us. And when I scanned her, I saw, using a transvaginal probe, of course, I saw a bulky uterus measuring 12.4 by 8.5 by 7.7 centimeter. Therefore, our findings are in keeping with that of Saka and Abu Ahmed, that measurement greater than 12 centimeter not where uterine fibroids are not seen may be associated with adenomyosis. So we decided to look at it again. What else did we see? We saw global frontal enlargement, and then we saw small myometrial cysts, and then we saw shadows, and then we saw indistinct endometrial myometrial junction, and then we saw echogenic islands. All of these are terms that are used to describe adenomyosis. Now, why did we have those inconclusive or misleading reports initially? In actual fact, why should we have inconclusive reports at all? We found answers in these unpublished data where we sampled fertility specialists in order to better understand barriers to utilization of gynecological ultrasound. And what did we find? We found that the major reason why we have inconclusive or misleading reports concerning adenomyosis is lack of ultrasound scan skill. Menakaya and I, in this paper, identified the apparent lack of ultrasound scan skill to be due to the absence of formal training programs, with many imagers, sonographers, sonologists being often self-taught, unlike in high-income countries where gynecological ultrasound is a core, is a part of the core curriculum of specialty training. So, in training, sonographers will learn how to identify the sonographic features of adenomyosis in order to avoid misdiagnosis. Language really matters. And so this consensus statement from the Musa group has presented us with both a language to describe the sonographic features of adenomyosis and a system of how to identify it. I invite you to read the paper because, again, it also provides guidance on how to distinguish uterine fibroids clearly from adenomyosis. So further refinement of definition by the Musa group has led to the recognition of the sonographic features of adenomyosis as primary features or secondary features. The primary features usually they signify the presence of ectopic endometrium, and they are seen on ultrasound. They are also called direct signs. They are seen on ultrasound as myometrial cysts, hyperechogenic islands, or subendometrial lines and boards. While the secondary features also called indirect features. These are indicators secondary to the presence of ectopic endometrium. So you may see them on ultrasound as asymmetrical thickening of the myometrial wall because of the distribution, localized distribution of the adenomyotic tissues. Here in this place, they are distributed more to the posterior wall. So you see posterior wall thickening. And where there is a uniform distribution of the adenomyotic lesion, you see global uniform enlargement of the myometrium. You may also see fan-shaped shadowing, transitional vascularity, and then the endometrial myometrial junction may be interrupted or it may be irregular. Now, recall that in the first scan from the clinical case presentation clinical case scenario we presented, the sonographer used both the trans-abdominal probe and the transvaginal probe. The second sonographer used the transvaginal probe. But adenomyosis is best visualized using the transvaginal probe. Why? Because it's not possible to get a good image resolution with a trans-abdominal scan to enable a reliable distinction between adenomyosis and uterine fibroids. So what is recommended? It is recommended that the transvaginal probe, transvaginal scan should be the primary tool in all clinical cases of suspected adenomyosis. However, in Nigeria, there are still some reservations about the acceptability of the transvaginal probe or transvaginal scan as a diagnostic tool. However, these most recent publications showed us, they concluded that the transvaginal ultrasonography is universally acceptable to women in Nigeria and recommend that ultrasound scan providers should acquire this key for transvaginal scan and then aim to use it routinely in all gynecological evaluation. And when eventually this skill is acquired, what will these ultrasound providers see? Look at this image. They will see that the fundus of the uterus is enlarged globularly. They will also notice asymmetry in the anterior and posterior myometrial wall. But like we said, these are secondary signs or indirect signs, secondary features. So you look deeper. You ask yourself, why do I see these things? When you look deeper, you see loss of endometrial myometrial junction, and then you see shadows, more in the transverse image, you see shadows, and then you see myometrial cyst, and then you see echogenic islands. So when you put your probe and you scan the patient, the first thing you see are indirect signs. Then you ask yourself, why do I see these signs? Let me show you some video examples. Now, Bloom and Majidohom actually showed that we learned from them that sonographic features of adenomyosis are best demonstrated using video clips. So I'll show you my own videos. These are my own videos. So in this video, you see that the uterus is globularly enlarged. Again, more at the fundus. And then as you scan, you see a fibroid nodule, and you shout to the car, the fibroid nodule must be the reason for the enlargement. And you decide to measure it. And what do you find? You have 0.8 by 1.2, 1.12%. No, it cannot be. That's like a seed of granite. That cannot be the reason for the enlargement, 0.8 by 1.2. So you scan further, and then you see asymmetry of the anterior and posterior myometrial wall. And then you see that the anterior myometrial wall appears wider than the posterior myometrial wall. And then you notice that the myometrium is heterogeneous, hypoechoic areas, hyperechoic areas in the anterior wall. So what do? You scan further. You scan further to look at this region of interest, the anterior myometrial wall that has hyperechogenic lesions right there. So you zoom your image. You zoom in your image. You zoom in your image, and then you see the hyperechogenic areas. What do you see? Myometrial cyst. Myometrial cyst. See the cyst with the echogenic rim, cyst with echogenic rim, cyst with echogenic rim. So, and then you switch on your Doppler just to see what type of vascularity is this. Switch on your Doppler. Yes, switch on the Doppler. So you see the echogenic rim, myometrial cyst. Doppler is coming soon. Myometrial cyst, Doppler is coming soon. Switch on the Doppler. Yes, switch on the Doppler, and then we see translesional vascularity. The vessels go through the lesion as if there is no lesion. Okay, now let us look at our fibroid nodule and see the type of vascularity the fibroid has. Look, this is where the fibroid is. You will see circular flow, distinct from this translesional vascularity of the adenomyosis. Look at it. See circular flow here, just telling you where the fibroid is, distinct. So the fibroid lesion is well defined. The adenomyosis lesion is ill-defined. That's the difference. Now, let us look at the junctional zone. Again, look at the junctional zone in this image. Look at how the anterior myometrial junction is well demonstrated, very clearly demonstrated. And you look at the posterior zone, not well demonstrated. See that? So, see, well demonstrated here. Again, look at this image. This retroverted uterus. You see global fundal enlargement, yes. But what strikes you first are the shadows. Look at the shadows, fan-shaped shadows, fan-shaped shadows. Look at the shadows, fan-shaped shadows. And then you see, why do we have these shadows? You zoom in again, and then you see the myometrial cyst, echogenic rim, myometrial cyst, echogenic rim, myometrial cyst, echogenic rim. So you see that. These are the features of adenomyosis. Again, if you switch on your Doppler, you see translesional flow. Okay. So how did these cysts really appear? Look at it. The cysts are anechoic structures surrounded by echogenic rim. Look at the cysts here. They are the single most reliable sign for the diagnosis of adenomyosis. So you see cysts here, echogenic islands all over. Then you see shadows, that's in the direction of the ultrasound beam. Ultrasound is generated by the waveforms. You see that? So when you see shadows, there must be a reason why the shadows exist. And here it is quite simple. So I put this image, this video, so we can understand how the shadows arise. So we have here a cyst, quite a large cyst, and just below the cyst, you see acoustic enhancement. You see that? Acoustic enhancement. And on either side, you see edge shadowing. So we see a large cyst, we see acoustic enhancement, retroacoustic enhancement, and then we see shadows on either side. Now, if it was a smaller cyst, you just see linear hyperechoic stripe alternating with linear hypoechoic stripe, so like this one. Yeah, a good example of shadows. You see that? Hyperechoic shadows, hyperechoic lines, stripes, alternating hyper. If you move up, you see the cyst. Look at the cyst here. You just saw a cyst. So it's actually shadows alternating with retroacoustic enhancement, shadows, retroacoustic enhancement, shadows, retroacoustic enhancement in a grossly enlarged uterus. And if with further skill development and better machines, we'll be able to see subendometrial lines and boards. And then you look at it, you see the subendometrial lines and boards, This must be distinguished from echogenic spots, which are actually progenitors of echogenic islands. And so here you also see the subendometrial lines and boards just below the endometrium, infiltration of the endometrial myometrial junction. And if you have 3D, you can reconstruct the uterus and then you'll be able to see the actual infiltration of the endometrial myometrial junction like this. Look at how beautiful this area is, and then you see the infiltration in the corner point here. Again, the lateral left side wall here, you see the infiltration. There are usually perpendicular lines between the myometrial wall.
Hello? Hello? We need to say,
Was I muted? Hello?
yeah, you are off for some time. Yeah, you're back. So go on. Yeah, that is the broadband, the broadband. So we might pause for a few minutes to allow Dr. Agolo to come back. Yeah, I must say that Dr. Agolo is not in Lagos, is in a part of Nigeria called Warri. And so sometimes this happens. Hello?
Am I back now?
Yeah, you're back.
Am I back now?
Yeah, you are.
Okay,
No,
so can my screen come back?
Sure. Oh,
My
okay.
screen, can my screen come back? Can my screen come back, please?
Yeah. 1 minute. You have to share your screen again.
Can my okay.
You have to share your screen again.
Yes. Yes, share it again. Shared. Thank you so much. Thank you. Am I back? Opomu, can you hear me?
Yeah, you're good.
Okay, good. So like I was saying, I was saying that I hope we all followed the aspect. Can I go back? Where can I go back? Yeah. Yes. I talked about the possibility of 3D reconstruction of the uterus, and then us being able to, of course, see junctional zone infiltration. And that's where we were before I got cut off. Okay, so now we see that it is possible to diagnose adenomyosis using ultrasound. So it is quite sad that despite the availability of this knowledge, adenomyosis continues to be misdiagnosed in Nigeria, and that surgeons continue to be surprised by what they find at surgery. And patients continue to be surprised to learn of surgical findings when they are awake. many times going back home with the problems that brought them to the hospital in the first instance. Problems of abdominal uterine bleeding, pain, dysmenorrhea and dyspareunia, subfertility, and challenges with a poor obstetric outcome. This needs to stop. Menakaya and I proffered solutions along three needs. One, provision of good ultrasound scan machine with, of course, access for servicing, repairs, and maintenance. But we talked about training and retraining. It never ends. And of course, we talked about the need for accurate reporting of ultrasound scan images using technological tools like DISCOM or even prepared available templates for gynecological ultrasound scan reporting like the forms that are available. Sorry about this. Yes, we could use Monaco or Viewpoint. Those are systems that are available that can be used in our setting. So let me summarize all of this for you. Yes, ultrasound scan diagnosis of adenomyosis is available in Nigeria, but what we know is that available evidence indicate that we are still lagging behind the global community in the appropriate use of transvaginal ultrasound as the first tool for the diagnosis of adenomyosis. As a result, misdiagnosis of adenomyosis and application of inappropriate treatment continues in Nigeria. Researchers have identified lack of training as a major challenge. Therefore, there is a need to provide training opportunities if we are to improve accuracy in ultrasound diagnosis of adenomyosis, especially as treatment options, including HIFU surgery, are available now. Thank you.
Thank you so very much. Thank you so very much, Dr. Agolo. You put it so clearly, the need for us to be able to diagnose adenomyosis pre-surgery, because that's whether for surgery or for IVF, that is when the patient can benefit, not after. So, and you have highlighted the importance of training. So thank you so very much. I have the pleasure of inviting the next speaker to, now that we've been able to make the diagnosis of adenomyosis, surgery for adenomyosis, and Hans Sternenberg will be talking about this. So Hans Sternenberg is not a stranger to many of us in all these endometriosis things that we organize. We know that he's a pioneer president of the European Endometriosis League. He has authored so many publications, and he's on a very limited time schedule today because he has a family thing to do. But thank you so much, Hans, for creating time to talk to us about surgery for adenomyosis. So I hand over to you, Hans.
Thank you, Yomi. It's a great pleasure for me to be with you. And I hope that we might be able to extend this in the future to come. And as you said, we have spoken about endometriosis related topics before, and I hope we will do in the future. Now, I am very grateful to the previous speaker, Dr. Akolor, because he had stated something that I think might change the entire attitude to endometriosis, including adenomyosis. And it's only because of that that I also took one ultrasound picture. This is a 3D pic, and you can see the disproportion, all the other signs that Dr. Akolor had shown. And I would like to add one aspect, and I will come back to this at the end of my talk. We have the privilege of doing the ultrasound or the diagnosis and the treatment in one hand. So it should be that also the surgeon should learn to read these ultrasound findings, because ultrasound is not only easier available, but it is also a dynamic investigation. And therefore, we can have an excellent approach to this type of disease. This is an MRI finding, and I had this because the advice that I have heard most by gynecologists is, okay, sorry, we now know that you have are suffering from adenomyosis, and we recommend hysterectomy. This is no option for women that have still not completed their family planning. And if they want to have a child by themselves, then they need the uterus, full stop. There's no discussion about this. And this is why I am propagating not to further entertain the idea of hysterectomy, but to look at other options. And I'm very grateful to Dr. Abayomi Ajayi that he has also alternatives to certain ways. And of course, what we can do is site reduction. We can try a complete excision. We have non-surgical interventions, and we also, in some options, might have medical therapy. Up to date, medical therapy for particularly extensive adenomyosis, mainly diffuse adenomyosis, was the only way, especially in case of infertility, that was recommended. And I'm sure that Dr. Ajayi knows all the stimulation protocols, including long-term GnRH analog downstaging. What I would very much like to talk about is complete excision, which is sort of conflicting with site reduction. Now, perhaps some of you know a surgical technique that has been propagated by Osada from Japan. The technique that I am practicing is slightly different from this, because my former teacher had propagated a technique similar to this, but in a slightly different way. But this picture is fine, I think, to explain what it works like. So what we do is we place a tourniquet around the ascending branches of the uterine artery. We also have a tourniquet around the ovarian vessels, so that the ovaries will still be perfused. We do not set a clamp here, but we set a clamp here, and the tubes will recover. So there is a tourniquet here on both sides and a tourniquet at the isthmocervical level. Then we split the uterus in two parts. Probably this is not very obvious, because we split that. We also open the uterine cavity. Then, and I'm doing this with a mini laparotomy. I take the uterus out in front of the abdominal wall, and then excise with a bipolar scissor. I excise all the affected tissue by having one finger in the uterine cavity, and with the bipolar dissecting scissor, I excise the tissue, leaving part of the junctional zone intact, as well as part of the subserous normal myometrium. There's always normal myometrium, sometimes only a very thin layer in this area, and this is also some healthy tissue. So if you like, this is the maximum way of site reductive way of going about. Here you can see there is the finger is in the uterine cavity. This is the bipolar scissor by Erbe, called bisect, and I dissect this tissue and remove it on in 4 areas where there's the main diffuse adenomyosis at the posterior anterior wall, and the same at the posterior wall left and right sided. So there are 4 areas where to dissect. Here you can see this is also going close to the uterine cavity. Here you can see that there's little normal tissue left. So as we also try to remove even small islets of this tissue. And here is a short video that shows you all the tissue all the adenomyotic tissue has been removed. And now we suture the edges of the uterine cavity with Vicryl. Vicryl 3-0, sometimes 2-0, depending on how thick the tissue is. And these are sutures without any forceful knotting. So this is just for approximation. We do not want that there are rough edges inside the uterine cavity. The uterine cavity, because of the endometrium, has a high capacity of reforming the layer of the uterine cavity, and this is what we can trust to depend on. And you can see there's very little oozing. That's because of the tourniquet. And some people have asked for how long can we leave the tourniquet. The tourniquet, I think, can be left up to 6 hours or even more. The uterus is extremely resistant to ischemia, but we do not need to have this. So, and now we will do additional incisions in order to have flaps that are overlying, because what we want to do is we want to reconstruct the uterus, and that's why I'm doing an additional incision in order to have an overlapping of the tissue to strengthen the uterine wall. Basically, this is the most creative work, and this is why it is always a new challenge, because what we have to aim for is we have to reform the uterus in a way that there are hardly any pockets left behind, because we do not want that there are seromas developing or that there are hematomas in these layers. And you can see what we do is we fold the tissue in a way that we have overlapping, also filling the possible gaps with healthy tissue. And this is now no longer Vicryl. This is PDS, because PDS takes much longer to lose its strength. It takes about 3 months in order to have half the pulling strength. And now, as you can see, this has been the first or the second layer, and this is now the third layer, which is also used in order to cover up the entire tissue. And we pull it together. Sorry, this is a head camera, so if someone is looking for something, by the way, the cameraman is my dear and respected co-worker, Dr. Aline Konstantin, who is also doing this type of work in a very, very nice manner. And you can see we are covering it, reconstructing the uterus so that in the end, the shape looks similar to what it should have looked under normal conditions, as you can see. So this is now the uterus. We remove the tourniquet, and this is how the uterus looks now. And in order to reduce the chance of developing seromas in there, what we also do is we place U-suture in order to as you can see, there's a straight needle and it goes front to back through the uterus. It is an U suture, a U suture. And this U is in order to compress from outside. It also goes through the uterine cavity to compress all these layers so that there is less chance of developing a seroma or even a hematoma. Okay, in order to avoid adhesion formation, we will perform thorough rinsing, and sometimes we even apply an anti-adhesion device in order to prevent this. So this is what this is a different case, but this is how it might. The tubes have, because now is being removed, even introduced a also we also propagate to use the, there is FA, which stands for adenomyosis, endometriosis, and this classification used pre-surgical, so that the patient less of my disease in imaging. How long will the surgery take, and that you after other aspects that might not have been seen. The Frankfurt way of the Osasa, one contribution to having not only more, to showing up ways of how to deal with those, and for all of that we need more awareness. It could be passed through Frankfurt or being there, and let's discuss things together if you like.
Yeah, thank you so very much, Hans. Yes, definitely. Just wait for COVID to go by, and then I'm sure some of your listeners will take up the knocking on your door in Frankfurt. Anyway, thank you so much. We'll just, I think we take all the questions together. So, oh, but you need to run. Can we just take a few questions? Do you want? Can we just take a few questions?
Yeah, but oh, I got the sign. The internet connection is a little unstable. So let's try it. If not, I see that active. If I cannot answer this, think doing so. But please, let's try.
Okay. All right. And I have a first question to start with. Have you tried to look hysteroscopically at the uteri that you have done this reconstruction for? Have you tried to look at it? What did you find if you have done that?
Yes, we have looked at it. We looked at it. We did not see intra to be afraid of, and we did not see any hysteroscopic related topics. I think an excellent speaker to show this, but most important, involved in infertility treatment. These were highly fertile, even though they had with IVF, ICSI, and what have you. So it really helped them having a baby.
I think what we just do is we get you to answer the questions. I think the internet is not our best friend here now. We just get you to answer the questions and then we can read the questions. Is that okay? Great. Okay, I think what we just do, can we... Go on, go on.
Me the questions or...
You have a lot of questions, so maybe...
can you understand everything?
Oh, yeah. Then we can even send some of them to you to answer, no problem.
Is unstable, so...
Yeah, I know. We just let you go, Hans. You be sure that I'm going to bombard you with the questions.
Yomi, if you don't mind, perhaps if people are really interested in this, you can send me their answer, or alternatively, I see that Harald
Harald is talking next after you now, so yeah.
Internet connection is better, so that he might answer this question.
Okay. Thank you so much. So, Harald, you have...
I'm sorry if I'm holding you.
No problem, Hans. You attend to what you've got to do. Okay. Thank you for being part of this. As usual, you're always very helpful. Harald, so you have extra headache added onto you now. As we come to you.
So much. And I will be happily answer the questions.
Yeah, so let me just introduce the next speaker. Yeah, I can say from all the comments that people are really having a good time with all this. Adenomyosis is a topic we cannot be tired of talking about. So the next speaker is Harald Krentel. He's a specialist, of course, gynecologist and obstetrician, and he's a certified gynecological oncologist and a specialist in minimally invasive surgery. Especially, he specialized in stereoscopic and laparoscopic procedures in adenomyosis, including adenomyomectomy and cytoreductive procedures in infertility. Krentel is a very important and very active member of the EEL. And so he'll be sharing the experience with us. Krentel, Dr. Krentel, is really my pleasure to have you here today. And now that you also have, you have inherited part of Hans' questions there, we're going to have a lovely time talking to you today. So, Harald, I just let you do your thing. Okay, then. Okay,
perfect. Yeah, first of all, thank you so much for your very kind introduction and the invitation. I'm very happy, and it's a big pleasure for me to be with you today. I think it's an excellent idea to have a webinar just on adenomyosis, as it is a very, very important area of patients with endometriosis. We should always think in all our patients with endometriosis, also in adenomyosis. And I would like to congratulate the previous speakers for their excellent lectures. Especially ultrasound is the most important tool in the detection of adenomyosis, as it is available for most of us in our daily practice. And as Hans said, we also do the ultrasound and the surgery. And if it's needed, we have radiologists to do an MRI. But the most important point is that we think in adenomyosis and that we try to diagnose it. That's the condition for the treatment, and it's the condition for complete counseling of our patients with endometriosis. And in this point, it's not important whether they have symptoms like bleeding disorders or dysmenorrhea or infertility. In all aspects, it's important. And as Dr. Agolor mentioned, also it's important to distinguish adenomyosis from fibroids. Now, my topic today is hysteroscopy in patients with adenomyosis, and I think it's an interesting surgical field in adenomyosis. First, before I start with hysteroscopy, I just would like to show you the new hashtag NCN classification of endometriosis, which has been published in February this year. Hans already showed it to us. I think it's a very important classification, as it is a comprehensive description system for endometriosis, including all aspects of the disease. And I'm talking about peritoneal lesions, but also deep endo and also adenomyosis. When we have a look at the classification, it's important to know that you can assess it by ultrasound. And that means that you just put a U, and that means the ultrasonographer is able to have a pre-surgical classification of the disease. The same can be achieved by MRI. And then you can have the surgical classification of the disease. And the best way is to merge your ultrasound, MRI, and surgery, and then have a clear view of the special and individual classification of each patient. When we talk about adenomyosis, it's the FA, which determines adenomyosis in this classification. And as you can see, it would be helpful to have an additional unique adenomyosis classification, which still does not exist. So why is adenomyosis of such a great importance? It has a very high incidence, and we do not know exactly how high. As we heard before, in previous years, it was just diagnosed by hysterectomy specimen, and now we just start to see and to care for adenomyosis. So we do not have exact dates on prevalence and incidence in age-depending way. So we do not know if a 25-year-old infertile patient has got adenomyosis or not. Just when we are very good in ultrasound, or we have good radiologists who are able to interpret MRI, then maybe we can detect it, but still we are not sure how often adenomyosis plays a role. The uterus is the central reproductive organ, and when you think in the older times, we talk about endometrial, about peritoneal endometriosis, about the ovaries, and about a lot of details, but we did not care about adenomyosis in the uterus. Most of the patients with adenomyosis have symptoms, another important factor, and adenomyosis, and I think this has been shown clearly so far, has a negative impact on fertility. It can cause reduced pregnancy rates, reduced birth rates, and higher abortion rates. And there is also a link to obstetrical complications like premature birth, PPRM, uterine rupture, and PPH. So this is what we have in our daily practice, and adenomyosis plays an important role. Which are the treatment options? Medical treatment, surgical treatment, and of course, reproductive treatment. And there are many options and many things to discuss. I will focus on surgical treatment and on hysteroscopy. The treatment factors for your decision taking are symptoms, family planning, additional deep endo, and patient's age. So when we talk about the surgical options, there are many, and as Hans showed, the open surgical resection, the cytoreductive surgery. You can also use laparoscopic resection. You can use radiofrequency ablation. You can use HIFU, which we will listen to later. And now we focus on hysteroscopy. When we resect adenomyosis, it has the effect that the pain is reduced, the bleeding disorders can be reduced, and this is also measurable in terms of CH12.5. There are some examples, and I just would like to show you these videos because it is important to understand that adenomyosis in some cases is clearly visible, but in many cases you just find subendometrial microcysts, like in these very young patients. These are typical findings, and here you can see how it looks like when you cut off the specimen out of such a uterus. And this is a 3 millimeter chocolate bubble, and this is a subendometrial adenomyosis finding, which can cause symptoms and the problems we just heard. So the idea now is, what can I do with hysteroscopy? Is it possible to see these lesions or to resect these lesions? We will see. This is a larger diffuse adenomyosis, and of course here in this case it's easier to detect, and this is nothing you can treat by hysteroscopy. And what we usually see in hysteroscopy is that the endometrium is irregular with tiny openings on the endometrial surface. We have a hypervascularization. We have the so-called strawberry pattern. We may have fibrous cystic appearance of intrauterine lesions, and we may have hemorrhagic cystic lesions. This is a review from 2017. And of course, the hysteroscopy is always good for the inspection of the uterine cavity, as you just mentioned. So what we do hysteroscopy in all our patients with endometriosis. This is our standard procedure. We use the trophy scope by Karl Storz, which is a 3 millimeter diagnostic hysteroscope. We do not use any dilatation. We do not use any medical pre-treatment. This is just the typical standard way to do hysteroscopy in all patients with endometriosis. This is just part of our fertility checkup. And sometimes you have some findings, like, for example, here, adhesions or a septum that you can treat. But of course, in most of the cases, there is no finding at all. And you just see a normal uterine cavity, and you just can tell your patient, okay, everything's perfect inside. And I can tell you that in many patients that have adenomyosis, the endometrial layer is completely normal. In some cases, it looks like this. This is not the video is not running well. However, these are typical findings, like these brownish cystic lesions, these spots in the endometrium. And sometimes you have these findings in hysteroscopy, but in many cases of adenomyosis, you just have a healthy, normal endometrial layer. This is an example for a small opening, the tiny opening of the endometrium. It's not the tube, it's an opening to a cystic adenomyosis. This is how it histologically looks like. This is resection of cystic adenomyosis with the bipolar loop. And this is a small adenomyosis lesion within the myometrium. And as you can see, we are just like dwelling in the depth of the uterus, and then you have an endometrial-like tissue again, which is very interesting when you see it. And of course, it's even more interesting when you have the chocolate coming out. The problem is that when we try to do hysteroscopic resection, the frequency that we really find our lesions is not 100%, of course, because sometimes the lesions are big enough and it's easy to detect them, but sometimes they are very small, and then it's really difficult. So if you want a histological proof and you want to have a small biopsy by hysteroscopy, then it might be difficult to find the lesion. So, for example, in the actual German and Austrian and Swiss guideline on endometriosis, there is no recommendation for obtaining a biopsy in patients with adenomyosis by hysteroscopy. However, I think it might be important, and if you combine ultrasound and hysteroscopic biopsy, you have a more or less high specificity, like in this publication, about 90%. We have some data too, and we were able to find the proof, the histological proof of adenomyosis in more or less 50% of those patients with a suspicion of adenomyosis. So you can see that it's not so easy, and of course it depends on the size of the lesion. The problem is that you have a lot of false negative results. Why could a histological proof by hysteroscopy be important? Because it might have consequences on the plan. It might have consequences on reproductive treatment, on surgical treatment, and it might be an explanation for the ongoing problems of the patient. And it might also be a factor for the coverage by health insurances. So we believe that if you see adenomyosis, you should try to get it resected. Here is another example. This is a cystic lesion. This is the proof by Doppler that it's not a vessel. And this is the result, as you can see. Of course, this is not a hysteroscopic resection. And here you can see how we do the biopsy in patients with adenomyosis. In this case, you can see that there's a certain strawberry pattern. There are these small lesions in the endometrial layer. This is a mini hysteroresectoscope. It's a 5 millimeter resectoscope bipolar, which is really good for fertility patients because you do not have to do a dilatation to 8 or 9 millimeters. Then you obtain the first layer, which is the layer of endometrium and junctional zone, and maybe a small layer of myometrium. And then in the same tunnel, you take the next layer, which is a deeper one with the myometrium. And then the pathologists have the chance to detect if there is adenomyosis or not. But just to repeat this, of course, in some cases, you need ultrasound in the OR. You need a good description of the localization of the lesion. Here it's easier because it's bigger and you can just resect it, and then you see the opening in the uterine wall. And this is a case of a much larger cystic adenomyosis, which we treated by hysteroscopy. So one thing is hysteroscopy as a diagnostic tool, and the other thing is hysteroscopy for biopsies, and the third thing is hysteroscopy in use for adenomyosis resection. This patient did not wish to conceive in the future, which means that we can just evacuate the cystic lesion and coagulate it inside like an ablation. But of course, if this patient would have an ongoing family planning, it would have been much better to do the surgery by laparoscopy in order to suture the uterus, or even by open surgery in order to have a good suture on the uterus, because this is a large defect of the posterior uterine wall. And you can see that now when the brownish liquid comes out, it's a cystic lesion filled with endometrial tissue. And what we do next is the ablation of this area. And this is a minimally invasive treatment instead of hysterectomy, and the treatment was successful and she left the hospital without pain. So it would be recommendable to take a small biopsy, a small resection chip, in order to have a histological result, and then you can do the ablation with a mono or bipolar loop. I recommend that you use bipolar, because these procedures might take some time. So this is another case that is also adenomyosis. It's cystic, but as you can see, it's on the sorry. It's not reachable by hysteroscopy. This is a 17-year-old patient, and here's the uterus and there's the lesion, but it's too large and it's too far away. That's why we decided to do this one by laparoscopy, and it's just opening it, and then the resection of the adenomyotic tissue. And this was the hysteroscopy in the same patient. So it was completely normal. Any finding, very young patient, 17, as I told you, with severe dysmenorrhea, no bleeding disorders, but dysmenorrhea and absolutely normal uterine cavity, and with a very beautiful endometrial layer, completely healthy. So if you do resection of cystic lesions or adenomyosis, of course, it's a save the uterus technique. It's hormone-free. It has a high impact on bleeding disorders, and it causes less pain. But of course, there's a uterine wall defect. You have no suture when you do it by hysteroscopy, and it might be less safe regarding malignant transformation when we talk about pre or perimenopausal women. So the conclusions are hysteroscopy, from my point of view, should be performed in all patients with endometriosis and ongoing family planning. Hysteroscopic biopsy is not really evaluated so far, but might be a good tool in some patients. You have the visualization during tissue sampling, and it's easy and minimally invasive. Of course, there are difficulties in deep or diffuse adenomyosis. You have false negative results, and you have to train your pathologist too. And just one issue, if you do resection and then you want to do a chromoperturbation when you continue with the laparoscopy, it might be a bit difficult, as the blue dye just enters the uterine wall and is not leaving the fallopian tubes. So you have to have this in mind. And I would like to take the chance to invite you, if you like endometriosis case discussions, to our EEL activity, which runs from time to time. Next time, 28th of September, 7 to 8 p.m. Central European time. It's just 1 hour of case discussion with Jörg Keckstein, Horace Roman, and Mohamed Mabrouk, and our young team. And of course, you are all invited to come to Bordeaux, France in June next year to our European Endometriosis Congress. We have a very good program, I think, and it would be an honor and pleasure for us to welcome you to Bordeaux. And I just can say, as Hans said, if you wish to visit our department in Germany, in Duisburg, you're always welcome. Thank you so much.
Yes, thank you. Thank you so much, Harald. Very, very lovely presentation. And one thing again that I really want to emphasize, especially for our colleagues in Nigeria, which is one of the things I've been discussing with you, is to see how we also not only train the gynecologists, but also the pathologists. And that's one of the things I saw from your presentation, because sometimes we bring out this and they can't make a diagnosis because they've not been trained to see this. So wonderful, thank you so very much. We have a lot of questions from what I can see, and then we inherited some also. So I think, fine, it's set so many people thinking, and I'm sure we'll benefit greatly from this presentation. So I just go on to talk about adenomyosis and infertility. So we made a diagnosis, we see that we can use the hysteroscope, but we know that a lot of these patients also have infertility. So how do we treat them? So that's what I'm going to be talking about in the next 20 minutes or so.
Perfect.
So thank you so much. And yes, adenomyosis and infertility, organized by SOGON, Endometriosis, European Endometriosis League, and Endometriosis Support Group Nigeria. Now, this we hopefully we translate into other things in our activities to train. The emphasis is actually how we can train ourselves to be able to, from Dr. Igolo's point of view, be able to make more diagnosis of endometriosis, adenomyosis with a scan. From Krentel's point of view, how we can use the hysteroscope, which fortunately we're using a lot now, more in Nigeria. From Hans' point of view, how we can use the laparoscope, and even the mini lab to treat this condition. So I'll try to start by defining what adenomyosis is, if you are not tired of hearing it. Benign uterine disease characterized by the presence of endometrial glands and stroma surrounded by hypertrophied and hyperplastic smooth muscles deep within the myometron. So it can be described as endometriosis of the uterus. So we see that most of the time, a lot of doctors mistake this for fibroids because there is bulky uterus, the symptoms are almost the same, and therefore it's not unusual to misdiagnosis as fibroids. The incidence, like we've heard so far, is unknown because we lack standardized definition and diagnostic criteria. Even the new classification is for endometriosis, not for adenomyosis. And therefore, prevalence is difficult to estimate. It's between 5% to 70%. And like Dr. Igolo pointed out in his own paper, which unfortunately is what still exists in Nigeria, we still diagnose a lot only by histology. And one of the things we want to take away from this series of activities is to increase our pre-surgical diagnosis of adenomyosis. And we saw there was a paper that was done in JOS recently that they saw up to about 35% of patients who had hysterectomy for fibroids, that about 35% of them actually had adenomyosis with the fibroid. So it's something that is very common here. The risk factors for adenomyosis, of course, is endometriosis, and that's why we're seeing it in younger people now. 40 to 50% of people who have endometriosis will also have adenomyosis. Smoking is also a risk factor. And of course, trauma, when you have done cesarean section, when you've done a curettage in the past, might be risk factors for you to have adenomyosis. Like we said, from what you've heard all day, the narrative seems to be changing because of the use of high resolution ultrasound imaging. From the typical story of the multiparous woman in our 40s and 50s, now we're seeing a lot of adenomyosis in our infertility clinics, especially now that childbearing is being delayed. People say in developed countries, but I think it's all over the world. Well, 30 to 35% of patients with adenomyosis might not be diagnosed symptomatic. So we need to pay more attention in making diagnosis, especially during our fertility evaluation, because sometimes this is the only time that this patient is actually seeing the gynecologist. Maybe they've been seeing other doctors before now, and we know, of course, again, the time interval usually between the diagnosis, the onset of symptoms in endometriosis and diagnosis being made, and especially in our environment where the chance to see the gynecologist might be very reduced, except when they have infertility. Well, from what we've heard from Dr. Krentel, several studies point to the negative influence of adenomyosis on natural reproduction. And there's several uncontrolled studies because of limited data that suggest that when you treat this adenomyosis also, reproduction or fertility tends to improve. So that is one of the things why even being able to treat adenomyosis with the hysteroscope might be very, very important to us. That if you can also debug the adenomyosis, at least this might improve fertility. Now, how do we link? Is there any linkage between infertility and adenomyosis? The answer is yes, there is definitely a linkage. And one of the papers I like is this one by Ileara Suhab. But she's based in Italy, working with some Swiss. And some of the things that they described in the paper titled Treatment Options and Reproductive Outcome for Adenomyosis-Associated Infertility. Some of the reasons they deduce are anatomical distortions, uterine dyspareunia, which affects sperm transport and implantation. And even a gentleman called Mehersab was able to see the different ultrastructure of smooth muscles in adenomyosis, different from the ones in the myometrium, and the loss of nerve fibers between the endometrium-myometrium interface in patients who have adenomyosis. And they also saw the altered vascularization in the secretory phase of the endometrium, which actually alters the implantation when patients try to get pregnant. Not to talk of the molecular markers like vascular EGF and all those cytokines that lead to OXA10 gene that are deranged in patients who have adenomyosis. But is there a causal relationship between adenomyosis and infertility? And the answer is no, there is no causal relationship. So the fact that you have adenomyosis does not mean you will have infertility, okay? And this was pointed out in this paper in 2019 by the group from Milan, Polo Vesellini. And so what do we do when we have a patient who has infertility and has adenomyosis? So the first thing is that we must have a comprehensive fertility assessment. Like we said, the fact that you have adenomyosis does not mean you have infertility. But if you have, then the first thing to do is to do a proper fertility assessment for the man and for the woman. And then we have 3 options available to us. And this is where actually the rubber meets the road. We have 3 options. Either we're considering surgery, we're considering the drugs, or we're considering ART. Now, it depends on who are we talking about. That's why it's important to individualize by doing your fertility assessment. So you look at what are the factors responsible. What is the age of the patient? Is this somebody who should be trying natural conception or who can try natural conception? For example, if all you found was just a focal adenomyosis, yeah, can such a patient try natural conception? For if you are trying natural conception, two options are either open to you. You can try surgery, you can try medications, and you can combine the two together. And if you're trying to do IVF, two options are so available to you. You can try drugs, you can try IVF, and you can combine the two of them. You can do IVF alone, and you can combine drugs and IVF together. So for someone who is trying to naturally conceive, and for, like we said, you found a focal lesion, and she probably has she's presented with current miscarriages, it might be important for you to try to do some of the things that both Dr. Krentel and Hans have spoken about. I saw in Hans's presentation this man's study, Gimbizi, who is from Thessalonica in Greece, who did a systemic review and described three main categories of uterine-sparing surgical treatment, which can be complete excision by adenomyoectomy. It can be partial excision through or cytoreductive surgery, and then you can have the non-excisional techniques, which Professor Ali is going to be talking to us about, HIFU. And of course, the other one is that we can be talking about uterine artery embolization. Now, when we talk about surgery for complete excision or partial excision, it can be by laparotomy, it can be by laparoscopy, and like Krentel described, it can be by hysteroscopy. Now, the problem most of the time is to achieve the balance between, like when Hans described the surgical techniques. That's why I asked for the stereoscopic finding. So most of the time, your problem is to find the balance between complete removal of adenomyosis and preservation of uterine contour. And there's also the risk of uterine rupture in pregnancy. And some even reports have shown that there is some PPH that is not responsive to conservative treatment, which leads to peripartum hysterectomy. And so I saw a question also, elective cesarean section after uterine sparing surgery seems to be the best option for delivery. So all these things are making there to be a push for the non-excisional techniques, even for patients who want to do IVF. And that's why Professor Ali's talk is very, very, very important. How we can do some non-excisional things, either we're considering HIFU or we're thinking of uterine artery embolization, of course, and the two of them serve different, the indications that are alike, but at the same time, a little bit different. But of course, we also spoke about the drugs. There are two groups of drugs that we can consider if we're talking about adenomyosis and infertility. The GnRH agonist. This, of course, reduces the free radicals in the glandular endothelium by suppressing the expression of nitric oxide synthesis. And of course, they also decrease the P450 aromatase expression, which enhances uterine receptivity. And the second group of drugs are the aromatase inhibitors. And there was a study done in Egypt, which was a prospective randomized control study, and found that there was no difference in volume and symptoms of patients who have adenomyosis at 12 weeks. But one interesting thing, he also found that the group that were using the aromatase inhibitors, 2 of them got pregnant, and none of the people who are using GnRH agonists got pregnant. Well, there was nothing significant to suggest about that, but it was just something that was noticed. So what about IVF in adenomyosis-related infertility? We've looked at surgery, we've looked at medications. Now let's look at about IVF. When it comes to IVF, the data is still conflicting, although many studies suggest deleterious effect on IVF outcome. That's what also Hara told us. The same way that adenomyosis affect natural reproduction, it also affects the outcome of IVF. And one of the good ones that earlier meta-analysis is one done by the group in Milan again. And they had a meta-analysis of 9 published data, which involved 1,865 women, 306 of which had adenomyosis. They concluded from this study that women with adenomyosis have a 28% reduction in clinical pregnancy rate due to reduced implantation and increased miscarriage rate. Grace Jones from Canada also went on to do one recently, another meta-analysis, trying to start from where the Milan group stopped. They did 9 studies. She went ahead and looked at 15 studies, 11 of which were observational studies, and 4 were prospective studies. And this study involved 2,054 women, 519 with adenomyosis. She obtained also a similar result, but also showed that there was a 41% reduction in live birth rates in women who had adenomyosis. This is also another review article which showed another systemic review and meta-analysis, which is much more recent. This was released last year, which adjusted for the age of these patients in the study. And he used 17 observational studies and found that there was still a lower clinical pregnancy rate in patients who had adenomyosis, and they also have a higher miscarriage rate after ART. And he also pointed out that this lower clinical pregnancy rate was more significant in patients who use short protocol, either agonist or antagonist downregulation protocol. And he also went to notice that there were some obstetric complications related to adenomyosis, just like Prentice pointed out: preeclampsia, preterm delivery, fetal malpresentation, smalls for gestational age infants, and postpartum hemorrhage. But this new study that was done this year from Australia by Higgins says that adenomyosis does not significantly affect IVF outcome, especially when you adjust for confounding factors, including maternal age and smoking status. You know that smoking is a risk factor for adenomyosis. But what about when we use donor eggs? Does adenomyosis have any effect when you are using donor eggs? Well, this was a study done by the group in Valencia, the Spanish group, and they used transcriptomic analysis of the endometrium of women with adenomyosis. And they showed that implantation rate may not be affected, but miscarriage rate is definitely higher in patients who have adenomyosis. Now, so the question is, what do you do in this when you have this conflicting data, what I call a cacophony? What do you do when you have this conflicting data? So we're going to try to look at what are the things that we can do. And one of the articles that shows that is that there is a lot of publications from China now on adenomyosis, okay? And so that's one of the things that is making us also to call on Professor Ali to talk to us about what their views are, especially when it comes to HIFU. But this review article by Lee is one of those ones that looked at what, and she pointed out the importance of prolonged downregulation in success of people who have infertility and have adenomyosis and are doing IVF. But this prolonged downregulation can be used in 2 ways. One is with pre-treatment, 2 to 3 months before your stimulation, and then you can do fresh transfer or preferably frozen embryo transfer. And also there was also talking about this pre-treatment was also this ultra-long GnRH agonist protocol, which involves so many spin-offs came up. Some people using OCP before you start your GnRH analog, or some people actually having 2 doses of GnRH analog on 2 different cycles. So this is also a possibility. But the second way to use this prolonged down regulation is that you could actually split your treatment into two. You first do your stimulation, and then you do your prolonged down regulation before you do your FET. So always from the get-go, you are splitting your treatment in your IVF treatment into two. You're doing your stimulation first, and then you do your prolonged down regulation. We've spoken about the advantages of what the prolonged down regulation, what GnRH agonist does to the endometrium. You want to maximize this advantage, and therefore, before you do your FET. Of course, this was a paper that was published by Strelny, who worked together with the Chaperon group in Paris. And they published this, and they showed us that you could actually do this, do your prolonged down regulation before you now do your FET. And this is one thing that I actually subscribe to, splitting the treatment into two, but that means your freezing has to be good if you are going to be able to do that. But of course, we can almost take freezing for granted now with vitrification. Now, is there any preferred protocol for ovarian stimulation? Yes, the jury is still out. Majority favor the long protocol or the ultra long or the modified ultra long, but people generally believe that you should do prolonged down regulation. I've told you that there are two ways you can do this. You can do it as pre-treatment before your stimulation, and you can do it just before your frozen embryo transfer. And this paper, another one from China, actually told us that antagonist regimen might be inferior to use when you have a patient with adenomyosis. Now, this is one other thing that I think we should take when we're trying to, because if you now have the embryos, it means your transfer procedure must be top-notch. And so mock transfer, embryo transfer might be something to always do for patients who have adenomyosis. This because it's particularly important in this group of patients because it may alert the clinician about the peculiarities at ET. For example, what kind of catheter should you use? Should you start from the get-go using your stylet due to uterine distortion? But all this information might just be necessary for us to optimize the treatment that these patients are going to have. So I just draw the conclusion by saying that we need to draw more attention to screening for adenomyosis, especially in infertility management. The frequent coexistence of adenomyosis with endometriosis and fibroids might just prove a double whammy for some of our patients who are faced with infertility. There is still limited data available concerning the efficacy of the different treatment options for infertility, and therefore still pose a major challenge to gynecologists and fertility experts who are faced with these patients. And adenomyosis may be responsible for a good percentage of repeated implantation failure. I'm sure this is one word that many people who practice IVF really dread, repeated implantation failure. So, but adenomyosis might just be one of the things. So this might be one of the reasons why we need to be able to diagnose more adenomyosis even before our patients start IVF treatment. Well, women with adenomyosis need special counseling when faced with infertility, as they may need multiple attempts, as well as they need good antenatal care due to possible obstetric complications. And I join others to say that we still need to do more than what we're doing now with adenomyosis. Thank you so much for listening. And I think it's just enough time for me to invite Professor Ali to just talk to us about HIFU and adenomyosis.
Thank you so much. So for all the speaker previous, they all did a wonderful speech. So for me, it would be easier. And I will share my screen. So here's screen. Okay. Dear all friends in front of the screen from all over the world, it's my great honor to be here to attend this beautiful webinar. My topic is about treatment strategies and the reproductive outcome for adenomyosis, HIFU as a new alternative. Talking about adenomyosis, the three gentlemen we should remember. Like first case we found in 1816, and Cullen gives the first discrimination, and Simpson is kind of the father of the adenomyosis. So again, coming. Dr. Ajayi, the screen is normal.
I can see you. It's good.
Yes. Oh, thank you. Thank you so much. So we should simply talking about the history and some reason for adenomyosis. So in 1908, Cullen proposed the basal layer endometrial invasion as a cause of adenomyosis, which may be related to the lack of submucose in the endometrium. Adenomyosis originates from the invagination of the bacillus of the endometrium into the myometrium. The bacillus invagination proceeds along the intramyometrium lymphatic system, a metaplastic process initiated from ectopic intramyometrium endometrial tissue. So here we should realize the problem for adenomyosis, the disease of the root of the disease is endometrium tissue. For simple clinical feature, we all know adenomyosis showing increase of uterine size, and the big problem is pain, dysmenorrhea, and some patients will suffering from anemia. And about infertility, Dr. Ajayi gave us a very good details already, and the happy abortion. So anything's not coming pure simply. So endometriosis also usually occurs in 50%. What's happened then? You may, okay. Sorry, my computer some problem here. My screen disappears suddenly.
No, but we can see your screen. I think it's from your
Really?
end. Yeah, we can see your screen.
But I can't move it, sorry. Suddenly stopped here. I will try again. Connect again. Sorry. Now it's okay.
Perfect.
Now it's coming wrong way. Okay. So from the back here. So yes, and about the fertility, Dr. Ajayi gave us very good details already. So this is about adenomyosis. Pathologically, myometrium hypertrophy was mainly observed with island-shaped endometrium gland and stroma distributed between the myometrium wall and smooth muscle fiber hyperplasia. This picture just look page. And for ultrasound, I believe every audience already get good information from Dr. Kinsley. He gave us a very good information from ultrasound, and the uterine MRI feature we will talk later. So we can see the mix and the scatter in multiple spots with higher signal foci. So for treatment, we already know we have drug treatment and some surgical treatment. I will focus on the new style, HIFU. So we should know, including any traditional technique like myomectomy, adenomyomectomy, we should think about what will happen later when the patient during the pregnancy. So there's some data report will happen obstetric complication such as uterine rupture. This is a case from another hospital. Also for hysterectomy, it's not easy for some women. They wouldn't like closed uterus. So what happened after hysterectomy? Loss of sexual desire. That is a very important thing in women's life. And the insomnia. And another big problem for some of women with SUI and POP, pelvic disease. About HIFU, I want to simply introduce, this is a new technique, no invasion, no bleeding, no transfusion, and the rapid recovery. I will show the very simple video here. So, okay. So we can see the patient just lying on the bed. So while treating, the patient can listening to music at the same time, just relax and lie there. The lower abdomen is soaked in water like a spa. So it can be said to be a very comfortable treatment. Simple history about HIFU. In 1927, when the report on the physical and biological effect on focused ultrasound. In 1942, Lin, this man is related some brain research. So they put some technique, but in the end, they were failed. In 1950s, Fry showed HIFU could effectively ablate target tissue without affecting the surrounding structure. In 1997, Wang Zhibiao, who is an inventor for HIFU, made the first therapeutic system and conducted the first in-man application for the treatment of bone cancer. So I saw these patients last year. They create a miracle. The family is very happy. And HIFU was first used for gynecological disease like fibroid in 2002, adenomyosis in 2008. I will talk about the very principle, the mechanism about HIFU. HIFU tumor therapeutic system convert electric energy into acoustic energy through a transducer, just the yellow color stuff. And the ultrasound emitted by the transducer is focused onto target tissue to confer treatment. The temperature at the biological focal region, just at the inside of the fibrous, can suddenly arise over 65 degrees. And the irreversibly cause necrosis immediately. HIFU offers one-time precise resection via conformal ablation of the lesion under the real-time monitoring by either ultrasound or MRI, usually ultrasound. So if the doctor very familiar with ultrasound, it can handle easier. So HIFU system already installed in all around the world in nearly 30 countries. So this is a big data center. It can connect everywhere. So in China, we can see nearly every province we already have HIFU machine. The left side the picture, we can see the all around the world. So 这个重新the happen problem again, I will share. So I'm not sure what's happened for here. 重新再用，无法恢复的问题。Yeah, yesterday we tried very good, so I'm not sure. Okay. again. Okay. When we're doing HIFU, the very important thing for classification, so today we already learned from Hans and the previous speaker, we have new system about classification, so that is very important. But this is our experience about classification. We according to the traditional way, like focal and the diffusion, and we divide into A, B, C. A means nearby the endometrium, B outside the nearby the subseries. C is a noodle style. For diffusion, also divide into the diffusion, endogenous, diffuse, extraneous, and the diffuse intramural. Three step. A different adenomyosis will require a different treatment strategy. So for HIFU, the best one is diffuse and endogenesis type and the diffuse intramural subtypes. For the purpose of HIFU, very simple, selective and precise ablation of adenomyosis lesion and reduce the scope of the lesion. Loss of endometrium function in ectopic endometrium. The very important thing is relieve the symptom. So this is data. We begin from 2050, the end of the year, but now we finished more than 2,000 cases. We increased gradually. So in whole China, we are in the third line. So every year nearly for more than 400. From this table, we will see that most of the patients we treat are adenomyosis, the green color, especially recent years. So our treatment strategy divided 3 steps. The first step is HIFU. The second step, we will use kind of medication like GnRHA and the progesterone. So any medication, the easier to get. The last step is resection of endometrium. So at the beginning, we mentioned this kind of disease mechanism is endometrium. So the third step, we usually will do the resection of endometrium through hysteroscopically. This is a paper we published 2 years ago for 3 steps. So this is a very typical case we done. So we will see from the picture A, posterior and adenomyosis lesion here before treatment. 1 day after HIFU, we can see the ablation area nearly 90%. And just 80 days after HIFU, from picture C, we can see the beautiful normal uterine size. So I call this technique like as magical as a work of art. So very big uterus, just 18 days can come in through the normal size. The beauty of the non-invasive technique. So just like a turnip, I have several patients after very huge myoma absorbed completely and after adenomyosis disappear. So the uterus size in the pelvic wall through MRI, we found the shape of the uterus like turnip, very beautiful. So here I will show the 4 minutes videos for all audience to show how the HIFU work. But I suddenly find the problem coming again. We can't running the video. Okay, I see. Maybe in the future we can see. So very interesting video. Actually, the whole procedure we can see easily. But after HIFU, we can see the improved VUS score And also menstrual volume score can reduce, and also reduce the uterine volume and increase the hemoglobin level. And the very typical marker, CA125, can dramatically reduce. So we will give the conclusion, the three-step approach, HIFU, GnRH, and the Mirena, it has lowest risk of hysterectomy. It's safe, effective, and efficient. It can improve the quality of life, especially for the patient with localized adenomyosis. I will share several successful cases. The first cases is 42 years, 5 years of dysmenorrhea associated with this hypomenorrhagia. So we have many patients getting through traditional treatment like GnRH several times, put Mirena, fallout, failed. So this patient also accepted 6 times of GnRH and 1 times Mirena without symptoms improving. So from this picture, the right side picture, we can see just 1 day after HIFU ablation, the whole lesion ablated nearly completely, and we caused the heart-shaped lesion. The patient will feel happy. Heart means love. So after 3 months, the uterine size coming normal, and we will do the step 3, hysteroscopic surgery to resect all the endometrium and put Mirena. And we sending the tissue to the biopsy. The pathology result is HIFU treatment induced high-grade degeneration of adenomyotic tissue. So this is about video for TCRE, so it can't work again. Another case is just 31 adenomyosis with severe dysmenorrhea and menorrhagia for 4 months. The very fresh case. So from picture we can see the mostly posterior adenomyosis lesion, but this ablation area is not very beautiful, but also it can work. The case 3, we can see the very huge adenomyosis. 1 day after HIFU, we can see another heart-shaped ablation area. 6 months later, the last picture is 16 months post-HIFU, smaller, much smaller. And another case, 32, severe dysmenorrhea for 4 years. So from here, we can see the ablation area, very beautiful. I want to show the multiple myoma, another different cases. So here we can see this patient very young, 29, haven't married when she accept treatment. She used the 6 times GnRH without symptom improving also. The diagnosis is diffuse uterine leiomyosis. So we can see we give 2 times ablation. 1 day after first time of HIFU, most fibroid ablated. 3 months later, we can compare the third picture with the first picture. The size of the uterus shrinks smaller, very beautifully. This patient, 30 years, 4 years of myoma. So we can here posterior myoma. 1 day after ablation beautifully, and just 3 months later, we can see much smaller, and the shape of the uterus is very beautiful. So the patient can easily pregnant later. This paper showing the HIFU treatment does not affect ovarian reserve, and the pregnancy outcome also very good. Here we can showing the conclusion. So this is 68 adenomyosis patient and 54 succeeded in pregnancy after HIFU. And the average pregnancy time is 8 months. In 54 patients who had a successful pregnancy, there were no symptomatic uterine rupture or rupture during pregnancy or delivery. So HIFU ablation has no obvious adverse effect on normal uterine wall and does not increase the risk of uterine rupture during pregnancy and delivery. HIFU ablation may improve uterine movement and uterine cavity. HIFU ablation result in the relief of clinical symptoms in adenomyosis patient with fertility desire. Our strategy about the adenomyosis is combination therapy. So we will choose a big lesion for HIFU. And after HIFU, we also combined with medication. But for some doctors, they like to hysteroscopic surgery, laparoscopic surgery, laparotomy, both are okay. We should choose a suitable technique for the patient. So in our center, we have 77 cases naturally pregnancy and 19 cases accepting IVF. Both of them deliver successfully. So for the adeno patient, we think should take individualized treatment. For small lesion without the desiration for pregnancy, we recommend the TCRE resection through hysteroscopically and put Marina. Large lesion without the desiration for pregnancy, after HIFU, we will give TCRE also. So combine the most suitable unique skill. So this is our cases, our first HIFU baby. In her 32 months, she accepted MRI to check the baby. So we can see the myoma. Before treatment, nearly 4 centimeters, but during the pregnancy, the myoma shrank gradually to 2.5. So this patient is our first HIFU baby. So we also have a milestone for 1,000 kisses, HIFU baby. Also the very beautiful baby here. So our patients give us flowers, mooncake, and this one is 1,000 HIFU baby. So we also create the club to help the patient. As we know, especially adenomyosis, the woman with adenomyosis or endometriosis usually have depression, anxiety. So we established a club to help the patient, including doctors and young doctors and patients. We will together sharing the experience to help the patient. For myself, actually at the beginning, I have a laparotomy skill, and then I have a laparoscopic surgery. I trained my primary laparoscopic skill in Australia with Peter Maher and Jim Salters, and also in Stanford with Cameron Nizat. So maybe we all know in America, US, they have 3 brothers, all they are very brilliant. And from 2015, with Wang Zhibiao professor, I changed to the HIFU therapy, no bleeding, no scar. But for myself, I can do hysteroscopic surgery, laparoscopic surgery, laparotomy, also HIFU. We usually choose the right skill to the right patient, which is the best to choose for the patient. So I also build my team. So I can't do anything by myself individually. So I have several students together. And I will give my summary. Effective treatment of symptomatic adenomyosis requires classification of the disease. Adenomyosis negatively impacts fertility and obstetric outcomes. So Dr. Ajayi already gave us a very good detail. The third, surgical myomectomy has a risk of surgical complication. HIFU has the advantage of non-invasiveness, favorable safety profile, quick recovery, and retreat capability. HIFU can selectively ablate the concentrated granular muscle lesion, reduce the scope of the lesion, and the ectopic endometrium lost the function. And the combined approach like HIFU, medication, and TCRE, resection of endometrium, is required for the effective management of adenomyosis. HIFU may be particularly suited for the patient with pregnancy desire, but requires more clinical study. And thank you so much, and sorry for my beautiful video. Thank you, Dr. Ajayi.
Thank you so very much. Thank you so very much. Thank you so very much. I think we've learned quite a number of things. And the president of SOGON is with us. I don't know whether he wants to say one or two things before we go to questions. Because we'll have quite a number of questions, and I think from the questions we just end. I don't know if the president or the secretary want to say anything, because I see the two of them are with us.
Okay. Hello, Professor Ajayi. Thank you very much for organizing this very highly educative session. And you've selected very good speakers who have done an excellent job on their presentation. Adenomyosis is not something that we commonly think about in our clinics. We only think of fibroid. So bringing it up to this level I think is very, very important, so that our young gynecologists can have it at the back of their mind, not only think of fibroid, but also think of adenomyosis, which is quite common in this environment. So thank you very much. I appreciate all the speakers. They've done an excellent job. And I can see everybody's, there are a lot of questions being asked. So it's really good to see this large gathering of excellent surgeons. One of them is a surgeon, she's a laparoscopic surgeon, and the HIFU. So thank you very much. We do appreciate this kind of gathering from time to time, so that we can educate people. I think I'm also happy with the attendance. I can see easily well over 200 people are attending this session. So it's really very good. Thank you very much, Dr. Abayomi Ajayi. Thank you.
Thank you, President. Yeah, so I think we just go to the questions, and we have a lot of them. We take as many as we can, and then we call it a day. The others will definitely answer and send to you. The first question, can Zoladex be used to treat adenomyosis? Should a patient diagnosed with fibroids and endometriosis and adenomyosis placed on Zoladex for 6 months, yet experiencing monthly periods with heavy blood clots, be worried? People say Zoladex makes you miss your periods, but the periods did not cease for 6 months. Okay, this is a patient who is asking whether she being on Zoladex for 6 months. Zoladex is a GnRH agonist for 6 months, and she's still bleeding, whether she should be worried. Okay. Well, it does happen sometimes. Maybe I just take that so because we have so many questions. It does happen sometimes that you still bleed even when you're on Zoladex. We expect that some people will not bleed, but some people still go on bleeding. And so, but there are other things that we need to look at. What other symptoms, apart from bleeding? Do you have any symptom that show that you are being downregulated, as it were? Or what about the fibroids? Is there anything happening with the fibroids? So I think it's a question you should ask, discuss with your doctor, but I don't think you should be worried just because you are bleeding. This is, how do you exclude the cyst in adenomyosis from degenerating fibroids and the echogenic shadows from calcified intramural fibroid using TVS? That's for you, Kingsley.
It was clearly displayed in the live imaging that I said. Majid Dohom had said clearly that the best way to display the images for adenomyosis is video clips. And in the video clips, you saw it. The cysts in adenomyosis, they are echogenic. You see anechoic central point and then the echogenic rim that surrounds it. The echogenic rim are actually what is described as the echogenic island. To understand this, you need to understand the pathophysiology of how the adenomyosis begins. First, there's a migration of endometrial tissue in subendometrium, and they come out as lines and bulge or small tissues, and then they migrate into the myometrium, and then they become larger. The central point of those migration now begin to menstruate, and the menses cannot exit. It is the locus that forms from that menstruation that forms the cyst. So they appear as anechoic lesions. And then when you switch on your Doppler, you see that there is translesional vascularity. Unlike in the degenerating fibroids, you will just see this circular flow that surrounds it. That distinguishes it clearly. Then the echogenic island from intramural fibroid, same situation. Doppler is the key. If you do not have Doppler, then you have a problem with distinguishing those two clearly.
Did not open the voice, Dr. Ajayi. Your voice is not open. Yes.
I'm sorry, I'm falling victim to this. Okay, I'm not sure if I heard right. I heard that the tourniquet on the uterus can be left for up to 6 hours. I need confirmation and clarification of this statement because many of us will not want to exceed 1 hour during myomectomies. Can one leave tourniquet in place for this long during myomectomies? This is a surgeon asking. I think that would be a question for, normally it should have been for Hans. So since you are inheriting his assets, Dr. Krentel.
Yes, well, when we do the Osara procedure, which is a surgery that we do in very rare cases, because there are some risks related to the surgery, like loss of uterus, like heavy bleeding, but also there is a high risk of uterine rupture during pregnancy or delivery. So this is something that should be last exit. And I think we have seen very good results by non-invasive techniques like HIFU, and maybe radiofrequency ablation can have similar results in the future. So when we do the procedure, I do not use that U-suture that Hans showed. I don't have any experience with that. So I am sorry, but I cannot answer this this question. There was another question about probable adhesion problem in the cavity.
I think I can answer the question, sir.
Sorry?
If you do not mind, I think I can answer the question. I do a lot of adenomyotic surgery repairs. Mm-hmm. So I have experience with that. And he's correct. You can, there's this, to be honest, when you look at this in the practicality of it is what we need to look at. When we were residents, they told us that when you are doing myomectomy, release the tourniquet every 20 minutes, release the tourniquet. The reality is that when you're operating, you cannot do that. That's the honest truth. When you're doing adenomyosis surgery, you've severed the uterus into 2 compartments. You cannot release your tourniquet and retire it. And those surgeries take a minimum of 3 hours. So I have done adenomyosis surgery for, the longest I've done was 9 hours for a particular patient. And I left the tourniquet in situ for that 9 hours. Patient is doing fine now. We're just recruited her into an IVF cycle, and then we're going to possibly conclude the IVF. Endometrium is very fine. uterus is fine. When we scanned her most recently, just before we recruited her for IVF, we did hysteroscopy for her, and the endometrium was quite beautiful. So she has no endometrial issues anymore regarding fertility. So yes, you can leave the tourniquet for longer than 6 hours that the German surgeon said, and I've done that, and I've seen that, and I have patients who came out with good endometrium afterwards.
Yeah, we should be a little bit careful about the pronouncements when there is no data. What is the effect on the ovaries? If you live for 9 hours, I'll be scared. You know, what is the effect on the ovarian reserve? Depriving the ovaries of the blood for such a long period of time. I think those are things that we should not just make a decision based on 1 or 2 patients. Is that something that we need to probably see if there's any literature on, and that's my own opinion.
And I would like to add that when you do the Osada triple flag technique, you usually do not leave any space for hematoma. That's the intention of this suturing. So there should not be any space left between the flaps, and then you may have a lower risk, and maybe the suture is not necessary at the end. So far, we did not do this suture, and we did not have any problems with bleeding. But yeah. I'm not sure. We have to ask Hans the next time.
Okay, that definitely will be the next time. Okay, so how do you differentiate adenomyosis from endometrial cancer on ultrasound with loss of boundaries?
The key is that this endometrial cancer is endometrium. You scan and you see that the endometrium is larger than normal. Adenomyosis is a disease of the myometrium, not of the endometrium. So the distinction is not quite difficult. When you scan and you see that the patient has endometrial cancer, it's the endometrium. The endometrium is larger than normal. There may be some infiltration, of course. There may be some infiltration into the subendometrium, but that can easily be distinguished from uterine fibroids. The size of the endometrium, and then Doppler. In endometrial CA, you have a Doppler score of 4. In the adenomyosis, you may have Doppler score of 2 to 3, not essentially 4. So those are the two things that you can use to distinguish them. Endometrial deposits like glands and buds are just minor deposits in the subendometrium, and the endometrium is particularly fine, no issues in adenomyosis. The key is that endometrial CA affects the endometrium, not the myometrium. I thought what you'd be concerned with is a sarcoma instead of an endometrial CA. In a sarcoma, again, the Doppler will help you because the Doppler will show increased vascularity of the myometrium as against for adenomyosis where the vascularity is 2 to 3, not essentially 4.
Wonderful.
If I may add something to that answer, there is a certain risk that you might miss an endometrial cancer arising in adenomyosis when you have, for example, a peri or postmenopausal patient, and this patient has myometrial adenomyotic cysts that can be a cancer developing inside. Of course, this is a rare condition, but it's difficult to distinguish these two diseases by ultrasound. And there's one thing that I have to add, because usually when endometrial cancer starts, the first sign is the postmenopausal bleeding. And when it's a cystic myometrial lesion, it might be a failure of this first sign of cancer. So you have a subgroup of post or perimenopausal and adenomyosis patients, and when they, for example, take hormone replacement therapy or tamoxifen for breast cancer treatment, maybe in this subgroup, hysterectomy could be helpful to avoid any problems, because it's difficult to check whether there is something irregular or not. But it's just a small group of patients, of course. Thank you.
Yeah, thank you so much. I'm trying to get some any effect of HIFU on the endometrium? That is for Professor Aldo.
Yeah, I'm here. Beg pardon, which question?
A doctor is asking any effect of HIFU on the endometrium. Does HIFU have any effect on the endometrium?
Oh yeah, it's depending on the technique process. So we will focus on the processing area. So usually we will leave the endometrium 1.5 centimeter. It never happened to destroy the endometrium or influence the endometrium first, but depending on the technique when you are doing. Usually would not happen, would not affect. After HIFU, our experience easily to get pregnant because in China, just last year before, they had a family planning, so one child policy. So many women around 40 or larger than 40 years old, they wouldn't like have a baby, but after HIFU treatment, easily pregnant, and finally they accept abortion is not good. So I wouldn't like my patient had abortion is not a beautiful thing. So our experience after HIFU, very easy to get pregnancy. And some of my patients said that it belonged to the HIFU side effect because they're suffering nearly 10 years pain, was not pregnant, nearly 10 years. So after HIFU, suddenly pregnant, so they can't believe. So what happened and had an abortion, and we will give the patients very severe recommendation after HIFU should taking the oral contraceptive pill to prevent pregnancy casually. Thank you. Will not influence endometrium.
Yeah. So
Yes.
Dr. Ali is telling you that what we do is that we avoid the endometrium. So we give a 15 mm space to,
Yes.
because HIFU is focused treatment. So you avoid the endometrium, give it a space
yes.
of 15 mm.
We will keep the safe distance from endometrium, from subserous bowel, anything. Just focus on the lesion.
Yeah, Dr. Bisu has made some comments here. And also Dr. Akinola, they made some comments here. Yep. Let me see, because I want us to finish in 2 minutes time so that everybody can. I'm so grateful that there's so many of you are still on. And okay, Dr. Disu was talking about edema formation seen post-tonically and is usually reversible. Yep. Okay, noted. Yeah, somebody asked a question. Okay, will GnRH treatment not alter natural fertility potential regarding ovulation capacity? If so, how would treatment of adenomyosis using GnRH impact on improving natural fertility potential? Yeah, actually it's not improved, well, it's improving it because your receptivity, uterine receptivity improves. We talked about how it lowers the aromatase, P450 aromatase. And so that's how we can use, reduces the radicals, free radicals in the endometrium, and therefore improves on the ability of the endometrium to actually fertilize. And that's one of the advantages that we have. Because, if you're doing IVF and you want to do the pre-treatment, you might not, especially for low responders, you might not get many eggs. Yeah. But for people who are normal responders, you might get something. But that's why we're now looking at, okay, we can do the prolonged down regulation after you have done your ovarian stimulation, and then you do a frozen embryo transfer. So, but also for natural pregnancy, it improves natural pregnancy. Thank you so much. I think at this point, we will just have to let go, although I still want to stay here, but I'm sure so many of us have been here for over 2.5 hours here now. So thank you so much for being part of this. Sogon, the president for creating time, the secretary for being here. It's wonderful. Oh, and the presenters, what can I say? You guys have just been lovely. Say me well to Hans when you see him. Harald, wonderful presentation. Kingsley, Professor Ali, wonderful. And so I need to mention some of the people who made this possible. The companies that made this possible: Electromedicine, the Fibroid Care Center, and ESDN, and of course, our partners, Haifu in Chongqing, China. Thank you so much for making this possible. And EEL, this is just the beginning. So what I would just say to Nigerians is watch this space. All right, then. So, see you guys, and thank you for being part of it.
See you.
Thank you very much.
Thank you so much.
Nice
Thank you.
to
Thank
meet
you,
you.
everyone. Thank you.
Bye. Thank you,
Bye.
all audience. Thank you.
Bye-bye.
Bye.